It's my pleasure to invite the last speaker of the session, Professor Mobeen Rathore. He is with us. He is a tenured professor and associate chair in the Department of Pediatrics, University of Florida, College of Medicine. He is presently working as Chief of Infectious Diseases and Immunology for Wolfson Children's Hospital, and a chair of Infectious Prevention and Control Committee, Baptist Health System. And of course, he has got a special interest in pediatric infectious diseases. Professor Mobeen Rathore. He will be talking about prevention and management of COVID-19.
Assalamu alaikum. Thank you very much for the kind introduction. I guess I should quick hurry this up because I'm standing between all of you and lunch. So I was asked to talk about COVID update on newborns, and this being a neonatology group, there's really not a whole lot of things that have changed for the newborns. So I'll try to present to you how we approach care of newborns who are exposed or infected, or not so much infected, exposed to mothers with coronavirus. Many of those things probably could not very effectively be applied in Pakistan, but certainly gives you the idea of how and what can be done. And obviously these things have to be implemented with the local resources and local cultural norms when you're taking care of newborns. I do want to remind everybody that we as pediatricians have been dealing with coronavirus for decades, and there are at least 4 coronaviruses that circulate in the community every year, and they are like colds. And they seem to happen every 2 to 4 years. I give you those numbers, which are meaningless because clinically they're all similar. And these, by the way, coronavirus infections, we know are much more severe when they happen in neonates. I'm not sure that with SARS-CoV-2, we have seen a similar severity, but I don't have that much experience in the actually infected neonates because we have not had many. So I think Dr. Manzini may have more experience with that in Italy, where there are lots of cases, I believe, with the alpha virus. We know that coronaviruses were more common, the previous ones more common in children than in adults. And let's not forget, there are other novel coronaviruses in addition to the COVID-19. There's the SARS, and MERS are the other 2 that we are probably most familiar with. So it was in mid-December 2019 that COVID-19 was identified as a cause of an outbreak of respiratory illness in China, in Wuhan, China. And of course, the WHO declared a pandemic. So we need to remind ourselves that this virus is still 2 years old, so we have a lot to learn about it still. And I think we should have the humility to know and understand that we are still learning about this virus. And new information is coming out every day, although the velocity of the new information has decreased a little bit, but it is still coming out every day. I do want to remind everybody, there's really no experts on COVID-19. And I use that in quotations because it's such a fast changing science that all of us are trying to keep up with it and learn and do the best. So I want you to remember 6 E's and this is extremely important. There's no experts, but on the other hand, everybody's an expert in coronavirus. So I think you have to be careful. When you don't have a lot of knowledge and expertise, you have to go by experience of people who have dealt with pandemics, epidemics, the infectious disease types. I've been practicing infectious diseases for 31 years and have dealt with several pandemics, epidemics, outbreaks, and we sort of train for all our lives for things like this, where we can extrapolate from previous knowledge and experience uh, and try to come up with the best scenarios. And when you hear Dr. Fauci talk about, he's sort of 80 years old and he's seen it all. And of course, he's a very smart man. And so I think he's most of his predictions came true because he was using his knowledge base to make those predictions. I think when we are talking about COVID-19, we need to have some common sense precautions. And as has been stressed today, hand hygiene stays the most important one with any infection prevention and control, but also for SARS-CoV. I always say soap and water is preferred, but you can use alcohol, any alcohol foam or liquid, which is at least 60% alcohol in it. And I was talking with Dr. Sajid Maqbool that, internationally, they say you should sing the happy birthday sound, and I timed it, and I think if you want to say Durud Ibrahimi, it's about the same time. So I think at least while you're washing your hands, that's the incentive for you to get some swab at the same time. So try to do that. You should wash your hands after touching surfaces in public places. I think it was alluded to that high touch areas, elevator knobs, door knobs, light switches, they are high touch areas and we don't think about them. A lot more people touch those. So we need to be sure that if we are going to be doing that, we use more hand hygiene. But it's also your own face and nose. We know from previous experiences when we touch our eyes and ear and nose and face, there is more likelihood of getting the virus on our hands. And of course, social hygiene, I think, is important, but I think we can go back to handshaking, but distances and hugging and kissing, especially for children, we should be careful about that. And never forget that we have all learned that there's a coughing and sneezing etiquette. And I remember when I was in medical school, we were taught that you should use a paper or something and then put it in this trash can, which had, I think it was the name of phenol hoti. But I think it is now more acceptable that you sneeze in your elbow, and it's better to sneeze in your elbow if you have a piece of cloth there, not on your bare elbow. And of course, clean and sanitize. It's overdone, but I think cleaning and sanitizing those high-touch surfaces is also important in prevention. And of course, as much as possible, avoid crowds and poorly ventilated spaces, and also avoid non-essential travel, although we are getting back to more of it as the pandemic sort of plateaus out. So I like this cartoon, and it says, although COVID-19 spreads mostly via mouth and nose, and scientists now conclude that the greatest risk comes from, you can fill in the blanks from that. So I think it's those people who are not willing to accept this, they are the ones who are causing most of the pandemic. Just to remind myself and everybody that there are certain important factors for the SARS-CoV-2 virus. The incubation period is about 4 to 6 weeks, or 4 to 6 days, and for influenza it's 1 to 2 days. And that 4 to 6 days is going to be important as I follow up on some of the things with neonates. The doubling time is 6 days, which is important, which tells you how the inoculum size can increase. And the R0 rate is 2.5, which is about double of what you have in influenza. So this can spread much quicker and faster. I think it's important that we all remember that the infectious period is probably 10 to 14 days. People now believe it's more 10 than 14 days. And the distance of spread of this virus is about 6 feet. Now, many factors play a role in that. If you have a fan behind you and you cough, it's going to go farther than 6 feet. So just remember those air movements make a big difference. And this becomes especially important in the hospital wards and when you're in the enclosed environments. And although this is controversial, but the virus can probably survive on hard surfaces for 2 to 3 days. I think there's still a lot of controversy about that. And it can stay suspended in the air for about 3 hours, which means that if somebody is infected and is especially in a closed environment, it can stay suspended in the air even after the person has left. And of course, many other factors play a role in that. So just remember some of these key and important factors of COVID-19. I like this slide because I use this a lot as code of conduct during the pandemic. I think first of all, we need to be calm and reassuring. I think I meant, I think Dr. Saab mentioned that I do infection prevention. I chaired the infection prevention and control for our health system, which is 5 hospitals, and I get calls all the time, especially when the pandemic was hot. And you always need to be sure that you're calm and reassuring, even when you don't really know the answer. And in the early on in the pandemic, we did not know many of the answers, but the people who are calling you and talking to you are looking for some calm and reassurance, and provide them with the best. You shouldn't make up things, but give them the best information. If you're going to be an expert in this, you have to make yourself available. And I think it's no point in trying to blame and just focus on the issue, what the best you can. You need to monitor electronic and social media, lots of misinformation out there, and maintain normal routines to the extent possible. And always be honest. If you don't know something, just say, we don't know that, or I don't know the answer to this, but based on my previous experience and knowledge, this is how we're going to do that. But try to remain as accurate as, don't make up things, is what I'm saying. You should know the symptoms of COVID-19, and more are being, signs and symptoms are being added. We are learning every day. And interestingly, it's kids' presentations are often very different. All these rashes, for example, that we have seen in kids that we don't see in adults. The GI symptoms are more likely in kids than in adults. Many of the kids that we saw early on in COVID-19, we thought had appendicitis. That's how they presented. And just discuss these new rules and practices. I'm going to show this slide to you very quickly, because as common as COVID-19 is, we are still going to see colds, just the rhinovirus and such, and influenza. We've not seen much of influenza, at least in the United States, during the pandemic. I'm not going to read this slide for you, but you guys can quickly read it. Basically say COVID-19 more likely to have fever and cough, as opposed to influenza, which has more likely fever, cough, and fatigue, aches and pains, and headaches. I actually got COVID-19 in the Omicron variant in January, and other than having fever, I didn't really feel very ill. Whereas in rhinovirus and common cold, there'll be more sneezing, aches and pains, runny nose, dripping nose, and sore throat. So these are sort of things help you, but these are not obviously. I want to show this slide also so that there is no confusion. You can again read this slide. Basically, the point of this slide is that the serology is useless. We should not be using serology for making a diagnosis or management decision for acute COVID. PCR is still your best test. I think the antigen tests are getting better. Home antigen tests can still be used. It's also probably a good use of home antigen tests in resource-limited countries. The antigen test is much more useful if the prevalence in the community is higher. When the prevalence in the community is lower, the antigen test is not very useful. We don't accept the antigen test when it is negative, but when it is positive, it is dependable, which basically I'm saying is the positive predictive value is quite good. The negative predictive value is not as good. Mother to child transmission of coronavirus, I'm now getting to what I was asked to speak about. There have been case reports of some transmissions. There's a lot of discussion there, how those were done based on serology and such. The jury is out on that still. But I think transmission from mother to child is possible. Intrauterine transmission. We know that perinatal transmission can occur, but more data are needed to have a virological confirmation of and reconfirmation of in utero transmission. So the routes of transmission are really primarily via the respiratory droplets. That's why it can go on for longer especially during the postnatal period when the neonates are exposed to mothers or in other caregivers. Now this is where things become different. We have to look at the resources and social norms. Newborns, when they go home from the hospital, everybody wants to visit them, give them hugs and kisses, and so I think we need to be careful that we are not exposing our children to caregivers, not just the mothers, but there are other caregivers who may be ill or may harbor the virus. I think I already talked to you about that. So what about the newborns who are delivered to mothers who are COVID-19 positive? This is something we are often faced with in my practice. Not very often, but still, almost, the 1 or 2 cases every week we have with a pregnant mother who is positive. I think if the mother is positive, we need to limit the number of caregivers in the delivery room. I don't know. Again, it's in the United States, the husbands or the father wants to be in the delivery room, and it's something that is really challenging to convince them not to be there, but it's something we have to deal with. If the mother is COVID-19 or what we call person under investigation or PUI, ideally you want to separate the mother from the baby in the delivery room, but I understand that's not always possible. So we have to work with the family, and we have to so they can understand. But if the family does agree to separate, mother can view the baby through the isolate or from a distance, and you should bathe the baby as soon as possible. So if the baby has been exposed to the virus during the birth process, at least that would help cleaning it on the surfaces. What's important is that there's no evidence of presence of the virus in the breast milk. So even if the mother is positive, breastfeeding should still be encouraged. I'm not sure how much breast pumps are used for the breast milk, but that would be one way. But again, this is something we have to meet with our social norms and cultures. And if the mother wants to breastfeed, I think, and she's infected, she can still breastfeed. You can ask her to wear a mask, or N95 mask preferably. And so I think we should not discourage that. You can still take care. She can wear a gown. She can wear a glove. Of course, the skin-to-skin touch is so important. So we are not very stringent on many of these things, but we often have a discussion with the family so they understand the risks. And most families, mothers, parents, grandparents, really want to protect the child. But if they don't know, then they may do some activities that may place the child in danger. So I think that conversation has to happen with the family before the baby is born, because the mother can get infected any time. And if you've already had that conversation, the final decision would be easier for the family and for you to participate in. If the mother is positive, let me step back. You do not need to test all babies when they are born. That is not required, especially if they're asymptomatic. And in your situation, especially the NICU babies, it's very difficult to separate out what is from their chronic lung disease or their premature lungs or other things that may happen in the NICU in these very sick babies, and what is COVID-19. So that's always a challenge. But I think, if they develop illness and you cannot be sure what it is, it's better to test the newborn than not. So I put that last point in there. Some are recommending that it is okay, doesn't matter, you can co-locate the baby, because when they go home, they are probably going to do whatever they're going to do. So that's why I think we cannot be too stringent, especially I think in our culture and I think I'm not sure, in the United States, most babies who are born in the hospital, majority of them are born, stay in the hospital for 48 hours. But once they leave, we can educate the family, but we really don't have any control what practices they will follow. So I think it comes back, we need to educate them, we need to tell them so they understand at least what the risk factors are. The clinical presentation of disease severity, babies can present like older children, fever, lethargy, rhinorrhea, cough, tachypnea, increased work of breathing, And you can see many of these things can happen in a premature neonate anyways. But children, as I alluded to early, seem to have more GI symptoms than adults do. Vomiting, diarrhea, and anorexia could be present. But we have to remind ourselves and remember the infections in the neonates are actually uncommon. They're even less common than what we see in older children. And when they do have majority of otherwise healthy neonates, I'm not talking about the NICU babies, otherwise healthy neonates, they're going to have either asymptomatic or mild disease. So I think that's something good, at least. There are reports from all over the world of otherwise previously healthy, I'm not talking about premature, otherwise previously healthy neonates who get infection and they have very severe respiratory illness, including mechanical ventilation and deaths in the neonates who got SARS-CoV as neonates. So, and it's a wide spectrum of illness there. And of course, preterm, I mean, I don't even, I mean, it's so challenging when I am consulted in the NICU, so I don't envy the neonatologist. Sometimes it's so difficult to tease out what is what. Forget about SARS-CoV-2. For all infections, all disease, sometimes it's, you know, what is a real infection and what is just the prematurity in the baby is so hard to do. So I'm going to mention what is recommended and then what I have recommended in our units since the start of the pandemic. Testing is recommended for all neonates who are born to mothers with suspected or confirmed COVID-19, regardless of whether they're signs. So if the mother is positive, because that's the highest risk. And of course, in our culture in Pakistan, we should also be thinking about the extended families who, you know, who all want to gather when the baby is born. I think I already mentioned this. I'm going to go to the bullet 3. I think that's important. The optimal timing for testing in the newborns after they're born is birth is still unknown. I think most people would agree, and most experts would agree that even though early testing is important, be ready because they can be both false positive and false negative tests. So I think the false positive could be because baby may be colonized, as you know, with HSV and other things. Baby may be colonized with the virus from the mother, and the false negative could be because the RNA has not replicated much yet, so it's not detectable. So I think that's what you have to be careful. And so that's where the clinical picture of the baby becomes very important, and with all the challenges I alluded to earlier. What is recommended for an exposed baby to get tested at birth? I have a little bit of a challenge with that. We do that in the United States. That's recommended. It's also medical legal reason. If the incubation period is 4 to 6 weeks, 4 to 6 days, and we say that most babies are infected not in utero but perinatally, then you don't expect the day 1 test to be positive. We still do it because that's what the CDC recommends. But I also, in our institution, we implemented that we also test them at day 7. Because if their incubation period is 4 to 6 days, by day 7, if they're going to be positive, they will be positive. We have not seen any positive baby at day 1. We have had a few, very few, I can count them on one hand during the pandemic, who were positive at day 7. And between day 1 and day 7, all these babies stay in isolation, not from the mother perhaps, but they are put in negative pressure rooms, and we do the HEPA filters and such. So we do that routinely until this day 7 test is also negative. I think I already talked about this. I'm not going to repeat that. What is the prioritization of testing? I think this is probably very apropos for Pakistan in areas with limited testing capacity, which I think I could be wrong, but the capacity is still limited in Pakistan. We need to prioritize it for neonates who are, there's some suggestive or clinical picture that suggests that the neonate may have COVID-19. So I'm not sure if you would be able to implement testing all neonates in all NICUs and nurseries. If we can, that's great. But I think if we cannot, I think we may have to wait and test those neonates who are either sick or for whom we expect to be in the hospital for a longer period of time, because they can certainly, if infected, can cause havoc in your nursery and the NICUs. Infection prevention and control, the same principles apply. The rates of SARS-CoV-2 in neonates do not appear to be affected by mode of delivery, the method of infant feeding, contact with the mothers with suspected or confirmed SARS-CoV. I don't know how many of you heard that we have a problem of a formula shortage in the United States right now. You can't find formula, which is, I wish we had the same thing in Pakistan. It would be good so people can do more breastfeeding. But I think there are some children, newborns, of course, who need a formula for their own health. Some others don't have as much breast milk. So I think it's a huge challenge. Is there any shortage in Pakistan? No. Anyways, I think if you cannot test the neonate or newborn and the mother is positive, while the baby is in the hospital, then you can't test the baby. You have to assume that the baby is positive and you have to manage in that manner. I think that's the safer thing to do. Again, once they go home, all bets are off. But I think, again, educating the family is important in that situation. I've got lots of information on these slides. These are based on recommendations. I don't know which part of that could be implemented. I went on the web yesterday and I saw that the government of Pakistan has a very nice algorithm how you can manage newborns during the pandemic. It was nice to see that. How many of you know about that algorithm? How many of you know that the government of Pakistan has an algorithm for managing newborns? But show of hands, please. Yeah, that's not very good. Only very few people know. So, yeah. So I want to say, Dr. Sajid Maqbool, that's one role PPA can play, because I thought it was a very good algorithm. I think it addresses the local needs. We cannot go by WHO and the CDC and the UK Health NHS. It's a locally, that's the most important thing. We need to have our local guidelines that are reality, not based on something that I come and tell you, because we have a lot more resources. I mean, we have an 80-bed NICU each individual room. And I've got 3 negative pressure rooms on each of those. We have 4 floors of NICU. So, you know, and if I don't have a negative pressure room, I can put HEPA filters in there. So I think this is something we need to have local guidelines that address the reality. And I think that's a very important. But if you do have, if the neonate does not remain in the mother's room, then you can consider institution of a capacity, your own capacity and your own resources, as well as the potential risk to the baby and to the others, healthcare workers and other babies in the nursery and the ICU, and develop your own guidance for isolation of those babies and how best you can do to prevent the transmission within the unit. Again, once they go home, same thing in Pakistan and same thing in the United States. You don't know what's going to happen. All you can do is you can educate them. I think the isolation of infants with suspected or confirmed infection in the ICU should be avoided unless the clinical condition warrants. Now, I'm talking about infants who are suspected and confirmed, not the mother. So what do you do now if the infant is positive? We are not recommending that they should be isolated from the mothers, because remember, the mothers can wear the N95. The mothers can come. It's easier for protecting the mothers. But we have not had that situation where the mother is negative and the baby is positive, but that potentially can happen in some situation. The other thing we have tried is in the nurseries and the NICUs as to discharge the babies as soon as possible if anybody in the family is infected, because it's really hard to monitor that who's going to transmit the infection to because during the pandemic, we did not allow grandparents to come in and the siblings to come into the nursery, the NICU, which was a huge dissatisfier for our population. But I think because of the resource limitations, I think it will be important if you know that the mother or any family member is positive, that you discharge the baby as soon as possible and as safe to discharge the baby. I think I'm going to move on to the next slide. I think I just wanted to put this slide to remind ourselves that the early and close, there's tons of data. The neonatologists know it much better than I do, that early and close contact between the mother and the neonate has well-established benefits. We all know the benefits of breastfeeding, but also the skin-to-skin contact, and which in our culture we have been doing forever. This is not new to us, but I think in the developed countries for a while that was not being done. So I think over the last 20, 30 years, maybe even longer, that's being encouraged a lot. And the ideal setting for care for healthy newborn while in the hospital is rooming in, not putting them into the nurseries if the baby is healthy enough to room in with the mother. That's always a better thing. That becomes, of course, a challenge if the mother is infected and the baby is not, or vice versa. Since the risk of the baby acquired the infection or mother is low, all the evidence is suggesting that, because when they have room in the United States, there were some hospitals that never implemented the policy of separating the mother and the baby, and the transmission rates were extremely low, extremely low. So I think there's a lot of incentive to not to separate the baby for the mother. So I don't want the people to leave that I'm recommending that. I'm just showing you what are the recommendations out there. We try not to separate those babies from mothers in our hospital, but we educate the families. And believe it or not, some families say, I'm going to separate them, for a little while, or, they all come up with some version of that separation. But most of the time, the babies and the mothers do have contact. I think I'm going to skip some of these slides. I think the next 3 or 4 slides I think are important, and I've gone through, mentioned this many times, but discussion on whether the neonate should remain with the mother room should include several important aspects. That is, can the mother learn easily how to respond to feeding cues of the baby? I mean, especially for the new mothers, they are learning these things. How you can tell, the experienced mothers can tell when the baby is hungry and when the diaper is wet, or when the baby is hurting. New mothers are learning that. Now, I'll tell you, in our culture, because even the young girls, they see these babies early on, they are much well attuned to those things. At least in the United States, we don't have that extended family situations. And so these young mothers, not so young mothers, have not had those experiences with newborns of their siblings' children or other cousins' children and such, so they may not be as well attuned to those. So that becomes very important for the new mothers, and I think we need to take that into consideration, especially once they go home. They need to be, as I said, attuned to those cues from the baby. And I think I don't have to convince this group that how important breastfeeding is, so that should be always taken into consideration. I think the mothers can still wear masks, practice good hand hygiene, minimize the risk of viral transmission. Maybe they can wear gowns, whatever the resources are available to them. The key thing should be the early bonding between the mother and the baby. I think that's important, not only for the mother, it's also important for the baby. I mean, these are probably things that are more appropriate or more to be discussed in other parts of the world. I mean, like rooming in promotes family-centered care. In our culture, babies live in the parents' rooms anyways, or the mother's room or the grandmother. They are not in separate rooms. And again, a lot of the babies leave the hospital very soon, and it's safe. And again, I have to keep on stressing this in several different ways. Mothers with suspected or confirmed infection should not be considered as posing a potential risk of virus transmission to the neonate if they have met the criteria for discontinuing isolation. I think, as I said, 10 days is when if they're symptomatic, after 10 days, if they're asymptomatic, that's fine. I put in there just to remind everybody that if immunocompromised or having severe or critical illness, then that 10 days is extended to 20 days. You also want to make sure that they are asymptomatic for at least 24 hours, which means that they don't have fever without antipyretics. So 10 days and last 24 hours of no fever. That's very important. And other symptoms may not have gone. The cough may be still there. The body aches may be still there, but they are getting better. They are improving. Then the mother can be considered uninfected. Again, I mentioned this, mothers may agree to temporarily separate the neonates. It may be more easier done in the in Pakistan than in the United States, because we have aunts and grandmothers and cousins. A lot of people are willing to help out. In the United States, we often don't have that luxury. So I think that's something each culture, each society, and the resources that we have. And we are lucky that we have that there are extended families who are willing to come in and help and support. I think the second point I've talked several times, when they go home, you just have to educate them. You have to tell them what to do, how to do it. You really have no control once they go home. What are some of the measures you can take to minimize the risk? If the neonate remains in the mother's room, some of the things the mother, as I said, can wear a mask, practice good hand hygiene during all contacts. You can do some engineering controls, maintain a distance of 6 feet between the mother and the baby. Mother can still see the baby. They can even do that at home if it's possible. Because obviously the babies, when they go home, they're sleeping most of the time anyways. But the feeding is the time then they need to be close to the mother if it's breastfeeding, especially if it's breastfeeding. But you can do those engineering controls in the hospital, but also at home. And again, I mentioned this healthy caregiver who's not in themselves infection is not increased risk for severe illness, maybe and can use appropriate infection prevention and control practices. They can be the caregivers, but don't forget, even those healthy caregivers, other than the mother, if they are involved, should also follow the appropriate IPC practices. Management, there's not much in management of the newborns. There's really no treatment. You just support them. We have Paxlovid that's not approved for newborns. The monoclonals are not approved for newborns. I mean, there's nothing really there. If they're getting very sick, you'll have to use Toci is not approved, but people have used that. Steroids have been used. Intravenous immunoglobulin has been used. So, for nothing is really approved for newborns, to the best of my knowledge. I think I'm going to, Dr. how much time do I've passed my time? Okay, I've gone too long. So I won't be able to show you, but let's just mention the fact that vaccines, if the mother gets, the pregnant women get the vaccine, that's the most important thing. They will protect the babies for the newborns in the first 6 months. That's also something that they can be protected. Even when the vaccine, the Moderna vaccine that's now going to be approved is for children 6 months of age and older. There's several, I don't know if you guys are going to have these slides available to you or not, but I'm going to, I'll stop there because I'm being told that I've passed my time and you guys want to go and have lunch. Thank you, sir. Thank you very much.
If there are any questions from the worthy speaker, maybe we can allow 1 or 2 questions. Please, sir.
Thank you very much. I don't think we could have asked for a better expert on COVID than you, and I'm glad you're here all the way from USA. It's not really a question, but I thought I might answer the query that you had posed, and I will tell you what we have done and sort of see whether that works equally well. We do not separate the mother and the baby. If we do, it is only until the testing that is done on the second day of life, which was one of the initial recommendations. We let the mother breastfeed. We encourage breastfeeding. Of course, we tell them to take due precautions, washing hands, wearing a mask. And then if the baby is kept in a separate room, the baby is brought back there and taken back for breastfeeding. Most families don't opt for separation. And in any case, the difficulty in our culture is that it's not only the mother in the room, but there are other relatives, like you've said, the grandparents. And so you have to be very, very careful. And so some degree of limited separation, if you can call it that, is practiced in many instances. But that's only for the first day or two. We have not seen any, or at least I have not seen any neonates with, proven COVID-19. And we have continued right from the beginning advocating immunizing mothers who were pregnant. So we've been following this routine and we believe very strongly in continuing breastfeeding and keeping them together, not really isolating them. We have tremendous difficulty in asking or convincing the parents to get another test done at 7 days or 10 days after birth, because once they leave the hospital, if the child is okay, they really don't want to do a testing. The second issue that interestingly, a lot of not only newborns, the mothers of newborns, relatives of newborns, but also of infants have is that they're very reluctant to get this swab up the nose to get the testing. So we do an oropharyngeal rather than a nasopharyngeal. I don't know, this is based on my experience. I don't know what the others are doing. So maybe Dr. Junaid can comment on this. So thank you very much for a very nice discourse as always.
Thank you for a very enlightening talk, sir. With regard to, sir, the future pandemic preparedness, there was a lot of talk about having flexibility in the hospital in terms of adapting to new environments. So Bill Gates talks a lot about pandemic preparedness. So, sir, a few pointers, some guidance about where we should go from here. Thank you.
Yeah, thank you. The question was some things about pandemic preparedness. I think we have learned a lot, at least in my 31 years of experience dealing with this. Is the worst of the pandemic. H1N1 was nothing like this. This is the worst of what I have seen. I think what the most important thing we have, so the pandemic, there are two parts of pandemic preparedness. There's the hospital-based part, but there's also the social, national, community-based part. I think that's the more important one. And I think we need to prepare our communities, our populations, that there, first of all, that there is another pandemic coming. Okay, we don't know when that is. By the way, those of you who follow influenza, we are due for influenza pandemic. Although H1N1 was 2009, it was not a real pandemic. I actually remember the 1967-68 influenza pandemic because I got influenza, so did a lot of other people in Pakistan. But it's been more than 40 years, and usually it's about 40 years or so that you get the influenza pandemic. So some pandemic is going to come. It may not be influenza, it may be another virus we have not even thought about. So I think we need to be, what happens is once these pandemics go away, everybody forgets about them, especially the authorities, the planning people, and they think that, I don't know if anybody has seen this movie Men in Black. I don't know, it's a movie about aliens, and there's a statement in there, this is, why do you keep on preparing for aliens? He said, there's always an alien out there. So the people who do what I do and what the CDC does and we are always preparing for a next issue. But unfortunately, the general public, it's not in their mind, and it should not be. But they should still have enough knowledge that the next pandemic comes, there's not resistance to vaccines. There is not this thing about, oh, this is all, America is doing this to make us impotent or something like that, or going to put a microchip or all sorts of issues, which, by the way, we have the same sort of crazy people in America who think these sort of things. And the government is trying to control us and things like that. I think to prepare the community to be accepting of some of these measures and that these are real things and these are going to happen again, other than going through a whole session about pandemic preparedness and the actual efforts, I think that's probably the most important thing we can do. Keep on talking about that there is going to be another pandemic. I think we need to have a local and indigent ability to make vaccines. I think that is such an important thing, that if we cannot make the vaccines locally, I mean, if we can make a nuclear bomb, we can make vaccines locally. They're not as difficult, especially with the mRNA technology. It's much easier than trying to produce the vaccine in eggs and all of that. With the mRNA technology, we should be able to produce mRNA vaccines in Pakistan. I think that's you asked me some things about sort of preparing the community and then having the ability to be able to make our own vaccines, because we cannot be dependent on China or something else to get the vaccine.
Thank you very much for a very nice talk. I want to ask about the experience of MISN, especially in US.
So the multi-inflammatory syndrome that we have MISC, we have seen a whole bunch of that. In fact, we had seen some cases which we, even before it was described by the I think it was the Italians and the UK first. And we had some cases which we didn't know it was MISC. And when we went back, so God, that was MISC. And our sickest children have been the children with MISC, not with the actual coronavirus infection. They were our sickest children. And I think initially they were, before we had this syndrome described, they would look like Kawasaki disease. And, there is no treatment for that. And we've been given IVIGs, people have given steroids, anakinra, some of the other immune modulators, but there is really not a good treatment, something you're going to do a monoclonal or a Paxlovid for MISC. But that's something that we expect to see about 4 weeks. Every time we have a surge, whether it's Delta or Omicron, 4 weeks after that, or 4 to 8 weeks after that, we start seeing we start seeing MISC cases, and we have to be prepared for that. But those have been the sickest children, by the way, not with the acute infection with MISC children that we have seen. Great question.
Thank you very much.
Thank you, sir.